This is about acute visual loss. I've listed out the common causes here and use short form to help your memory. Now think about the structure in the back of the eye. So for the vessels, you can have problems with the vein or artery. Now for the optic nerve, optic neuritis, NAION and AAION. AAION is giant cell arteritis, and these latter two are actually vascular related. For the macular, ARMD, and any causes of macular edema, it can be due to diabetic maculopathy, CRVO and BRVO. Retinal detachment is of course something you have to think about. The vitreous can also be opaque because of blood, i.e. vitreous hemorrhage, and also vitritis, which can be infective or non-infective. Vitreous hemorrhage could be caused by bleeding from new vessels, again CRVO, BRVO, proliferative diabetic retinopathy, or retinal tear or even detachment. Also remember your red eyes. Some of those causes acute visual loss, and always bear in mind malingerers, but that is a diagnosis of exclusion. It might not be acute after all. Occasionally you have a patient who turn up to you with an apparent acute visual loss, but it is in fact a pre-existing chronic unilateral visual loss that suddenly got discovered by the patient when the good eye is covered up. Imagine you are in the A&E department. During the history taking, think about these courses. You might have limited equipment if you are not an ophthalmologist. So 4 things: check the visual acuity and confirm the visual loss. Check the RAPD, you've learned that before. A positive RAPD implies optic nerve involvement or a very severe pathology such as ischemic CRVO. Now direct ophthalmoscope for red reflex and also fundus examination, and some A&E departments also have a B-scan ultrasound, and you could identify retinal detachment and vitreous hemorrhage with the instrument. We are going to go through some of the diseases. CRVO and BRVO both have retinal vein occlusions. So why is the vein blocked? This is due to arteriosclerosis. In the eye, the retinal arteriole and the corresponding venule share the common adventitial sheaths. So the thickened arteriole compresses the vein. That leads to venous occlusions, that leads to elevation of the pressure and causing stagnations of blood flow and therefore hypoxia. Now, that's why you see a very congested looking retina in the case of CRVO, with hard exudate, edema, and also lots of hemorrhages. In contrast, you see a pale looking cherry red spot in the CRAO. Now, the risk factors are listed here for your reference. CRVO could be classified into ischemic or non-ischemic. Ischemic CRVO is more severe, with severe visual loss, usually worse than 660, presence of RAPD, and also with presence of cotton wool spots. We have to monitor these patients carefully because we're concerned about complications. Complications include macular edema, neovascularization, so remember your NVD, NVE, and NVI. And in severe NVI, you can have neovascular glaucoma. These causes permanent visual damage. Treatment could be divided into systemic and ocular. Systemically, check the risk factor that causes the RVO. So blood pressure, other cardiovascular risk factor, take blood for hematological and rheumatological condition. For the ocular treatment, we treat the ocular complications that involve reduction of intraocular pressure if necessary, intravitreal injections of either anti-VEGF or steroid, and also pan-retinal photocoagulations or even surgery. Another cause of acute visual loss is retinal artery occlusion. We talked about that in the lecture. Just a little recap about CRAO. It is all about a pale looking retina instead of what you see in CRVO, which is very congested looking. There is ischemia of the inner retina, which means whatever is underneath is all covered up. Together with a cherry red spot at the fovea, because at the fovea there's not much tissue on top and you are actually looking at the choroid underneath. So classical signs during the acute CRAO are cherry red spots, retinal edema, and attenuated arterioles. You might see a visible emboli as well. RAPD is positive, and that's a dramatic loss of vision. CRAO is an ocular emergency. You want to rule out GCA, giant cell arteritis. And also there is a risk of stroke, so think about the carotid artery and also the heart and make appropriate referral. Complications include neovascularization, neovascular glaucoma, optic atrophy, and also ocular ischemic syndrome. We also talked about BRAO in the lecture. Most BRAO are due to emboli of different types. Antiphospholipid syndrome is also associated with multiple BRAO. Patient may present to you with a painless unilateral altitudinal visual field defect. Now, if you like, it's more like a milder form of CRAO. Complications, there could be neovascularization, but it rarely occurs. And you already got the slides on giant cell arteritis in my lecture. So remember, the specific associated symptoms, including jaw claudication, and the patient may feel very sick, non-pulsatile tender and thickened temporal artery, raised ESR, temporal artery biopsy is required to confirm the diagnosis, and the fact that high-dose systemic steroid is mainly to reduce the risk of fellow eye involvement. The macula is responsible for our central vision. Therefore, symptoms of macular diseases include central visual loss, metamorphopsia, meaning the straight line appears wavy and curly, micropsia, meaning the objects become smaller, and also scotoma. Now, scotoma could be relative or absolute. Absolute scotoma is like an area of complete blackout that blocks the vision, whereas relative scotoma is a blur area in the central part of the vision. Let's move on to ARMD, age-related macular degeneration. It could be wet or dry. To make it simple, in dry AMD, you have what we call drusen on the macula, which could slightly affect the vision or could be completely asymptomatic. But you can develop to another pathology called geographic atrophy. This is a nasty one that can severely damage the vision, and it is irreversible. Dry AMD could also develop to wet AMD, meaning that there is leakage in blood in the macula that affect the central vision, so patients have symptoms such as scotoma and metamorphopsia. And in ophthalmology, we do FFA and ICG to look for leakage and abnormal vessels, and that involve IV contrast injection. We can also do OCT, which is non-invasive. Treatment of AMD involves intravitreal injections of anti-VEGF and also photodynamic therapy, depends on the pathology. We also advise the patient to stop smoking, take a specific formula supplement called AREDS2, and also do regular Amsler grid monitoring. For patients with transient visual loss, it depends on how long it lasts, whether it is a few seconds, few minutes, or up to an hour. Also depends on whether it is unilateral or bilateral. I've given you a table here for your reference. Notice that the courses are all about vascular problem or raised intracranial pressure. Arguably, migraines is related to vasospasm. Another point is that transient blur vision happens in dry eye. The patient will tell you that the vision gets clearer after blinking and it is blurred again. May be associated with other symptoms as well, such as red eyes, pain, and photophobia. Intermittent angle closure is also another possibility. Patients don't usually tell you about it voluntarily. You have to ask them. And the symptoms is more or less like a mild and limited form of acute angle closure. For headache with ocular symptoms, think about the causes of headache that you have learned. For primary headache, migraine with aura, and cluster headache, secondary causes must be ruled out, and they are GCA, intracerebral aneurysm, subarachnoid hemorrhage, tumor, infections, and carotid artery dissection. I'll talk about floaters in a separate video. Of course, retinal detachment and vitreous hemorrhage also cause acute visual loss. Finally, be very careful when you encounter any of these red flag signs. This includes a very painful headache. The patient may tell you that it is the worst of his life. Signs and symptoms of increased intracranial pressure. Neurological deficits such as presence of cranial nerve palsy. The patient may feel very sick. And also be aware of other comorbidities. The patient may be immunosuppressed or on anticoagulants, and also pregnancy. And that's it. Bye bye.